Good evening, everyone, and thank you so much for joining us for tonight's Ask the Expert about managing side effects of hormone-blocking treatment with the very wonderful Dr. Michelle White. I'd like to proudly acknowledge the Bunurong people of the Kulin Nation as the traditional owners and custodians of this land, and I pay our respects to their elders, past, present, and emerging. My name is Kim Berchtenbreiter, and I've been a volunteer consumer representative with Breast Cancer Network Australia for just over 12 years, and I'm sure I'm as interested in this session as you, having gone through experiences of hormone-blocking treatment myself, so I'm looking forward very much to hearing what Dr. Michelle White has to say tonight. So the aim of this session is to enhance connection between the audience and share our experiences. And while this is not about specific individual medical advice, it is a safe environment to post your questions and hopefully have many questions answered. This session will address hormone blocking treatment and why and how it's recommended for treatment of early breast cancer and metastatic breast cancer. Just as an aside, metastatic breast cancer is also known as advanced breast cancer and secondary breast cancer. So Michelle White will talk about common hormone-blocking medicines for treatment of hormone-receptive positive early breast cancer and metastatic breast cancer. And in particular, she will discuss common side effects of hormone-blocking treatments. And I'm sure we'll all be interested to hear strategies and tips on how to manage these side effects to ensure a good balance of quality of life and risk of recurrence in the case of early breast cancer, or control of disease in the case of metastatic breast cancer. We'll be looking at bone health for the long term and options available for those experiencing very troublesome side effects from current medication. We have already been sent a lot of questions in prior to this event, so thank you to all of those of you who sent so many questions in. A little bit of housekeeping, please. If you could send in your questions tonight via the question box, so if you haven't already sent a question in and you have a burning question, via the question box, and you can chat amongst yourselves via the chat box. Any technical issues or concerns, please contact Redback Studios. And this event is being recorded and will be available on demand next week. So without further ado, I'm going to hand over to Dr. Michelle White, medical oncologist, who I just have to disclose also happened to be my medical oncologist, and very much looking forward to hearing what Michelle has to say. Thank you, Michelle.
Thanks, Kim. So my name is Michelle White. I'm an oncologist. I specialise in breast cancer, and I work both in the public system through Monash Health and also the private system through Cabrini here in Melbourne. I have a real interest in the care of patients with breast cancer, and I'm involved in clinical research both at a local and international level. But particularly recently, I've had an interest in the optimal management of menopausal symptoms associated with breast cancer treatments. I did a sabbatical late last year at the Royal Women's Hospital at their Menopause After Cancer clinic, and I learned a lot. So I'm really hoping that you find tonight helpful. So let's set the scene. Hormone-blocking agents, also known as endocrine therapy, is used to treat patients diagnosed with hormone receptor positive or estrogen receptor positive breast cancer. We know this is the most common subtype of breast cancer affecting both women and men, and these drugs are used to treat patients with early stage and advanced breast cancer. Now, for patients with early stage disease, unlike chemotherapy, which is given for 3 to 6 months usually, these treatments are given for very prolonged periods of time, and for early stage disease, as I said, somewhere between 5 and 10 years of treatment. The optimum duration of treatment for each individual patient is really dependent on a number of variables, but most importantly, it's really related to the tumour characteristics, as well as obviously the general health of a patient. I'm not really going to be able to go into a lot of detail about that tonight, and I'd certainly encourage any patient who feels they're not sure of how long they're going to be on their endocrine therapy to discuss this further with their treating team. Because it's long-term treatment for patients with early stage disease, it's really critical that we manage their symptoms as best we can. For patients with advanced or metastatic breast cancer, they too hopefully will be on these treatments for years. And again, when someone has advanced breast cancer, ensuring we maintain their quality of life is absolutely critical. And so it's really important, again, that we're aggressively managing any potential serious side effects. There are a number of different hormone-blocking agents, and they do work in different ways. So I'm just going to briefly go through the different ways that the drugs work. Tamoxifen works by binding to what's called the estrogen receptor, or estrogen gate, as I often call it, and it prevents estrogen binding to this gate and potentially allowing any cancer to grow. The beauty of tamoxifen is it works irrespective of whether you're a woman or a man, and if you're a woman, irrespective of whether you're premenopausal or postmenopausal. Unlike tamoxifen, aromatase inhibitors only work if you're postmenopausal. There are 3 drugs in the family, and they all are equally effective in reducing the risk of cancer returning. The 3 drugs are known as letrozole, otherwise known as Femara, anastrozole, otherwise known as Arimidex, and exemestane, otherwise known as Aromasin. These drugs work by preventing the production of estrogen in fat, which is the main way that a woman after menopause makes her estrogen. Compared to tamoxifen for a postmenopausal woman, this class of drugs are better at reducing your risk of breast cancer returning. However, for women who have low-risk disease, really there's very little difference between them. We can make a young woman postmenopausal either in the short term or long term by affecting her ovarian function. So in the short term, we use a drug called goserelin or Zoladex, which really works by tricking your body into being in a postmenopausal state, which is completely reversible if you stop the drug. And obviously, in a more final approach, you can take out a woman's ovaries, which is known as a bilateral salpingophorectomy. So let's have a look at the different treatment options we have available for women and men diagnosed with breast cancer. So for early stage disease for premenopausal women, there are usually 3 treatment options. And again, it's not possible in our presentation tonight to go through all the nuances of how you pick which treatment to give which woman. But certainly these are all very standard approaches that we would use. So the options for a premenopausal woman would either be tamoxifen on its own, tamoxifen with the agent stopping periods, goserelin, or an aromatase inhibitor used with the same drug. For a postmenopausal woman, the options are either the same 2 drugs, but we don't need to use goserelin in these cases. And for a man diagnosed with breast cancer, the treatment of choice is tamoxifen. For patients who've got advanced breast cancer, there are more hormone treatment options available. Again, we're using similar classes of drugs, as I've mentioned, the aromatase inhibitors. And for a premenopausal woman, again, they'd be given with the goserelin. And they're also given in combination with a new class of drugs called the CDK4/6 inhibitors, which aren't hormone blockers, but actually make the hormone blockers even more effective. Alternatively, tamoxifen can be used. Another agent known as fulvestrant, which has a different effect on the estrogen receptor, but is a very effective treatment. But with a premenopausal woman, again, needs to be given with this goserelin, or again, a woman could have her ovaries removed. For a postmenopausal woman, they're very similar treatment options to a premenopausal woman, apart from not needing to have ovarian function blocked. And for a man diagnosed with breast cancer, as I've mentioned, for early stage disease, tamoxifen is really the drug of choice. It gets a bit more complicated if they're not able to tolerate that medication. And then again, we've got to use goserelin for them as well as an aromatase inhibitor. and they have similar treatment options available if they're diagnosed with stage 4 disease. Most of the side effects associated with hormone-blocking medication are really those features of menopause. But some of the drugs have some side effects that are more common with one versus another, and I thought I would just highlight those before we go through management of the more general side effects. So we know that for tamoxifen, a very common side effect is weight gain as well as leg cramps. And there are two very rare side effects that cause great concern for many patients who are prescribed tamoxifen, and that is the very rare complication of deep vein thrombosis, which is a clot in the leg, or pulmonary embolus, which is a clot in the lung, and also the extremely rare side effect of cancer of the uterus, or endometrial cancer. For aromatase inhibitors, their more commonly seen side effects include the risk of osteoporosis or worsening of your bone health, or alternatively, joint stiffness is much more commonly seen with the aromatase inhibitors, as is vaginal dryness. Goserelin really just has general menopausal type side effects, nothing particularly specific. So I've put this list of 34 symptoms of menopause up just to really highlight how broad the physical and psychological changes of menopause and hormone blocking agents can be for a woman or man diagnosed with breast cancer and put on these treatments. Now, clearly, it would be rare for someone to have all of these side effects, but I'm sure there are people looking at this list and nodding in agreement at a number of these side effects. There are some women who get no side effects of natural menopause and no side effects of hormone blocking agents. And I've certainly got patients who say, Michelle, I wouldn't know I'm on the medication if I didn't have to take it every day. But it is important for those patients who do get side effects that they feel that there are strategies in place to help manage them. And this is something that I think is really important that we need to highlight for patients, particularly in this setting with early stage disease. We know that women and men are on these treatments for prolonged periods of time, often between 5 and 10 years. And if a patient is taking the medication and has severe side effects, then there's probably two potential outcomes. They're either going to stop the medication or remain on it and be miserable. And both of these are terrible outcomes. So it's really important that a patient has the trust in their treating team. They can bring up their menopausal symptoms and feel like they're being addressed and listened to. And one of the side effects that I think in the past hasn't really not been very well addressed in particular is the vaginal dryness / sexual dysfunction that we're going to discuss. I think many patients really took the philosophy, well, maybe I should just be happy I'm alive and not worry about that part of my life. But it is for many people a very critical aspect of their general well-being. And I think, moving forward, this is really something that as treating doctors we need to address. So let's go through each of the menopausal symptoms and how we might try and help deal with them. So hot flushes are the commonest feature of a natural menopause and also related to hormone blocking agents. They can affect a woman or man any time of day or night. And certainly a lot of people say, look, I can cope during the day, but when I become sleep deprived, when they're happening all night, that's really when I become desperate. Unlike chemotherapy, which has a pretty defined period of time that side effects might last, we know that often hot flushes do improve with time, but we don't know if that time frame is weeks, months, or years. And I've certainly got women in their 80s on hormone blocking treatments who are still experiencing quite serious hot flushes. We know those women who have the greatest drop in their estrogen level when they're put on these agents will tend to have the most severe symptoms, and that is really young women who've been premenopausal and we've made them postmenopausal, and women who've been on HRT, particularly those that have been on it a very long time. And really we take things very gently and slowly with those group of patients to make sure we're managing their symptoms really well. Hot flushes are really subjective. So some women say they can have 20 a day and it doesn't worry them, and other patients can have much fewer than that, but really be very distressed by them. There are some lifestyle things that patients can do to minimise their hot flushes. We certainly recommend that you avoid synthetic clothing, that you wear lots of layers, cotton or natural fibres at best. It's important, if you can, to avoid caffeine and alcohol later in the day. Many a patient will tell me they know if they have a couple of glasses of wine with dinner that they are going to have a rough night with hot flushes and they don't feel that's worth it. Spicy foods are also a precipitant, as is stress. And obviously for many patients, for example, getting in front of a crowd and giving a talk, there's nothing worse than having an episode where you're sweaty and go very bright red and feel that everyone is aware of what's happening. So it's really important, if we can, to manage these lifestyle factors. For women who haven't had breast cancer, HRT is often prescribed for management of hot flushes. But we know for women who have hormone-positive breast cancer that this medication should not be given. We have found, however, a few other medications that have been found incidentally to help hot flushes. So managing hot flushes is not their primary aim. They've got other functions, but when they first used them in clinical trials, they saw that women who used these drugs had less hot flushes. So some of the drugs we commonly use to try and help if lifestyle factors aren't successful include some antidepressants. So the one that's most studied is a drug called Effexor or venlafaxine, but another drug, Lexapro or escitalopram, is also effective. For patients who have a lot of hot flushes at night time, gabapentin is very useful because it's a drug used for epilepsy, and it's not only good at managing hot flushes, it's also a bit sedating, so it keeps you asleep. Other drugs that have been found to be effective is a drug called oxybutyrin, but it does cause a bit of a dry mouth. And clonidine, a blood pressure medication, was used a fair bit in the past, but less used these days. There are other approaches that are non-based on medication. We know that if you can keep your weight in a healthy range, that does help. Carrying extra weight does seem to almost insulate you and keep the hot flushes more internal and more intense. There's really good evidence about some psychological approaches, including cognitive behavioural therapy or CBT. But really, its use is a bit limited by the fact it's hard to find psychologists who specialise in doing this. And also seeing a psychologist regularly is expensive. So hopefully in the future there will be IT-based techniques such as apps that we can use to help patients with bad hot flushes. Hypnosis has also got good evidence to support its use, but again, it's kind of hard to find someone who can help guide you through that. Other lifestyle non-pharmacological approaches include yoga, which some patients find very beneficial. Acupuncture, there certainly have been some studies that have suggested it's helpful, but others that have suggested it's not. And unfortunately, to date, all the natural therapies that patients really would like to be successful in clinical trials, none have been found to be better than placebo. And there is quite an invasive procedure known as a stellate ganglion block that can be used, but it's an invasive procedure injecting into a nerve plexus in your neck, and it's generally not commonly done. So I've already mentioned sexual dysfunction a couple of times, and I really do want to highlight this is a common side effect of our treatments. It's related to a number of different factors: vaginal dryness, changes in body image and self-esteem, and obviously lowered mood, lowered libido, which is one of the, I call it the holy grail of breast cancer treatment, because to date we really don't have a good strategy to help with lowered libido. And it really is very distressing for some patients when they feel that they don't have the libido they had even, a few months before they started their treatment. And clearly relationships are challenged by a breast cancer diagnosis, and this can affect a couple's sexual relationship. So let's look at some strategies that we've got to treat the vaginal dryness. So when I mention vaginal dryness, many women think you're talking just about sexual intercourse. And vaginal dryness is much broader than that. For many women, it's about burning or itching that they certainly feel in the vulval area, which is very awkward. And it's also related to even procedures like having a pap smear done. I'll get many a call from a GP saying, look, I just can't do a pap smear. The tissues are so delicate and friable, they're bleeding so easily, I can't do the procedure. So it's not just about sexual intercourse, but it is a really troubling symptom for some patients. We certainly, again, turn to simple measures, lifestyle measures that can be used. Avoiding perfume soaps is really important. There are vaginal moisturizers, just like there's facial moisturizers, and there's an agent known as Replens. Again, avoiding synthetic underwear, using cotton underwear is much better. And for many patients, they can overcome this problem with the use of simple lubricants when they want to have sexual intercourse. Usually water-based lubricants are the best, but there has been interest in some vitamin-based lubricants, vitamin A and vitamin E. And many couples would experiment and try different lubricants and see which agent is the best for them. But for some women, these simple approaches are not effective, and really the only agent that's going to help with their symptoms may well be topical estrogen. So I've already mentioned that HRT is not recommended for women after hormone-positive breast cancer, and there has been concerns in the past about using estrogen in the vulval and vaginal tissues. However, we generally think, although initially when you start these medications, there might be a slight rise in the level of estrogen in the blood, that's not a sustained effect. And to date, there's not been a clinical trial that's demonstrated that these agents increase the risk of breast cancer recurring. But it's true to say that some oncologists are not comfortable with their use, and it does need to be a discussion between the oncologist and the patient to work out whether this is a treatment that your treating team are comfortable with. There's been a lot of interest lately in intravaginal laser. Just like laser can keep our faces looking youthful, intravaginal laser keeps our vaginas looking youthful, was the concept behind the idea. There was initial enthusiasm in doing it, but it is an expensive treatment, which financially was beyond the reach of many patients. There has, however, been a clinical trial recently published that's shown that really it didn't seem to be any better than what was considered sham laser, where they didn't have the actual treatment. And at this point in time, I don't think it's a treatment I would be able to recommend. And I certainly do think that sexual counselling can be really beneficial for some couples. However, again, it's really hard to track down a sexual counsellor, and there can be significant cost associated with this too. So let's move forward to musculoskeletal symptoms. We know that joint pain and stiffness, as well as inflammation of tendons and ligaments, is a common feature of natural menopause, and certainly commonly seen when patients are on a aromatase inhibitor. So any three of those drugs that I mentioned before. In clinical trials, when patients are having bad joint symptoms and they're moved from one of the drugs to another, about 30 to 40% of patients notice an improvement. So that's certainly my first strategy. But if a patient's tried a couple of these drugs and still the symptoms are really bad, I would move them across to tamoxifen, which causes much less joint issue. There are, again, lifestyle and other ways that we can try and manage the joint symptoms. There is a medication known as duloxetine, which can be helpful. But many patients will say, Michelle, I'm already on enough medication. I really don't want to add in another one, which is a completely understandable response. So really, there's great focus at the moment looking at exercise programs. Most of these incorporate both cardiovascular exercise and strength or core training. There's been certainly a randomised trial that did demonstrate acupuncture can be an effective treatment for these stiff joints. But again, it's hard to track down someone who has expertise in this area. I keep coming back to yoga. It's certainly a very helpful modality to keep your joints certainly as flexible as possible. Again, unfortunately, the alternative therapies to date of fish oils and glucosamine have not really been shown to be any better than placebo. And there's a bit of interest at the moment in curcumin, and clinical trials are underway, but we don't have any results to date. Okay, weight gain is one of those horrible side effects associated with menopause. And many women will notice that change in body shape that often happens with menopause, where they carry more weight, particularly around their abdomen and bottom. We know that there are a number of reasons why carrying extra weight is not good for a breast cancer survivor. It can have an impact on their hot flushes, as I've already mentioned. It may increase their risk of breast cancer returning, and it may also impact the effectiveness of the breast cancer treatments. And unfortunately, there's no simple way to lose the weight. And we know that losing weight as postmenopausal women is really, really challenging, and really it needs a combined approach of diet and exercise. But this is really something that a lot of women really fear with their hormonal therapy. And I really ask women to be really careful in the first few months on their treatment to try and make sure that this doesn't become an issue for them. We know that any stage of life where there's a change in hormone levels can be associated with a change in mood, with lowered mood and anxiety happening at times such as puberty and menopause. And hormone blocking therapy is certainly going to exacerbate this. In addition, if a woman's having uncontrolled hot flushes that's affecting her sleep, this will really affect her mental health. And I really think from a mental health perspective, early intervention for patients diagnosed with early stage and advanced breast cancer and men diagnosed with breast cancer is a really critical component of their treatment. And I really encourage people to consider this early in the piece. The number of times someone really fights with me about it in a gentle way, and then when they do actually receive mental support, they really find it very beneficial. I can't tell you how often it happens. As Kim mentioned, osteoporosis is certainly a recognised complication of menopause, and there's a number of reasons why patients going through breast cancer treatment will experience this. We know chemotherapy impacts your bone health, and early menopause can also do so, and aromatase inhibitors definitely have a negative impact on your bone health. So we really think it's important to make sure your calcium and vitamin D intake are adequate, that you're trying weight-bearing exercise, and there's certainly a number of physio and exercise physiology programs around at the moment which really are demonstrating great success in helping bone health for people diagnosed with breast cancer. But if other strategies don't work, there are other treatments available which are hormone-blocking agents that can be used. So not hormone-blocking agents, that are bone-modifying agents that can be used. Finally, there are two other side effects that can be really problematic for patients: insomnia and hair thinning. Insomnia is a challenging problem. I always ask my patients to take their hormone-blocking agents first thing in the morning, so it's as far away from the time of their going to bed as possible. And obviously all those aspects of good sleep hygiene, not using your computer late at night, avoiding caffeine-based products later in the day. But for some patients, it is a really big problem, and obviously we want to get their hot flushes at night time under good control. Melatonin's a drug that some people do find helpful, and I really try and avoid sleeping tablets at all costs, because you do develop tolerance and you need more and more of them to achieve the same amount of sleep. And finally, hair thinning is seen with all the hormonal blocking agents. I do find sometimes if you swap from one to another drug, you do see an improvement. And there are also dermatologists who specialise in hair thinning, but most of their drugs unfortunately make you generally hairy, and then you've got to deal with removing hair in other areas. So it is a challenging side effect of treatment. So in summary, these medications are really a vital part of treatment for the majority of women and men diagnosed with both early stage and metastatic breast cancer. And managing the side effects is important because of the long duration of treatment. And I do hope that patients feel comfortable talking to their treating team about what they're finding problematic, and also reporting back if they've stopped taking their medication. And I think just like it takes a village to raise a child, I see it as needing to take a village to care for a woman or man diagnosed with breast cancer. And it's a really multidisciplinary approach. These are not all the players, but they're important players who might play a role in the management of a patient on a hormone-blocking drug. And there are other resources out there. There's some really good websites, as I've written down there. And certainly in some states there are menopause after cancer clinics, and it would be worth speaking to your to BCNA or your local breast care nurse to see if that's something available in your area. And I'll stop there.
Wow. Thank you so much, Michelle. That was fantastic. We have had questions just flooding in, which is amazing, on top of the questions that we had pre-event. So we will try and get through as many as we can. I would have to say we may not get through every single question, and we can't necessarily talk to about one individual person's situation. So I would encourage you, if your question isn't answered tonight, to, if you're comfortable, talk with a member of your treating team, or you could always contact the BCNA helpline if your question doesn't get answered tonight. But hopefully we'll get through as many as we can. And I'll start with one that's come in on the question area tonight. Michelle, why is it necessary that we go on these hormone-blocking drugs for a period of 5 to 10 years?
Okay, well, that's a good question. And unfortunately, I'm old enough now that when I first started my training, we used to give the tablets for 2 years. And so the only unfortunate bit of that is that I'm getting very old, and that's a long time ago. But what they found when they first started doing clinical trials on the hormone-blocking drugs, and they compared 2 years of treatment with 5 years of treatment, they found that the outcome for women and men treated with 5 years of treatment had better outcomes. And then they started doing trials of 5 years versus 10 years. And certainly for higher risk women, they found the benefit was there of being on the medication longer. So it's all about essentially trying to minimise each patient's risk of the cancer returning, either locally, where in their breast tissue, or in other parts of their body with metastatic disease. But we do absolutely appreciate that because this is such a long period of time, we've always got to be balancing the benefits of our treatment between against the harm that what we might be doing with our treatment. But the evidence is there that somewhere between 5 and 10 years is the optimum duration of treatment. Yes. Pleasingly, when they've looked at longer term treatment beyond that, they haven't really seen the benefit is there. So that is reassuring that it's not in a couple of years' time they're going to start saying you need 15 or 20 years of treatment.
Even though I think some of us have felt over the years I'd stay on it for 20 or 30 years, because there's always that fear of coming off it when you finally finish it. So that's good to know that evidence-wise that it doesn't need to go beyond that period of time. Another question that's come in is, are the symptoms, or I presume that means of hormone-blocking treatment, accumulative? I.e., can you not have the symptoms initially and then have them occur 1 to 2 years later?
Yeah, that's a good question. Usually not. Usually the first couple of months will really tell the doctor and the patient how they're going to be on the treatment. And often things do improve with time, actually. So often patients will find that, for example, their joint stiffness or their hot flushes might be really quite bad for the first couple of months. But the longer they're on the medication, I do think maybe there's an element of your body getting used to the drugs. So it would be unusual to develop something much later. Hair thinning is something I do sometimes see later in the piece. So for patients who've been on the medication a couple of years, and obviously osteoporosis or impacts on bone health is a cumulative thing. But if we're talking about the common side effects of the hot flushes and the joint stiffness, they're usually an early phenomenon.
Okay, thank you. Are leg cramps a side effect? And how do you manage it?
Yeah, leg cramps are a menopausal symptom. So many women naturally going through menopause do find they have more leg cramps. And certainly women going through hormone blocking treatments do find more leg cramps, in particular tamoxifen. Some women can have really nasty leg cramps, whole legs or even abdominal muscles or muscles between their ribs. So they can be really painful. Magnesium is the best medication to manage hot flushes, to manage the cramps. There are other drugs that can be given, but they do certainly have more serious side effects. And most people do find if they use magnesium tablets or powder, and if someone keeps getting the cramps in the same muscle, some people do find massaging magnesium oil on that muscle before they go to bed can sometimes be helpful.
Okay, thank you. Is there an oncotype or oncotest for individual effectivity of hormone blocking treatment?
I'm guessing that question means tamoxifen versus the aromatase inhibitors. Do you think, Kim, that's what they might be?
I wondered if it was some sort of like, like Oncotype DX that
Yes.
shows whether you need to have chemo, or that is there a test that shows
so
which one would be best for you? I guess that's what I'm assuming that's what that means.
Yeah, so look, an oncotype does give you a percentage chance of cancer returning if you just use hormonal therapy, but it doesn't tease out which hormonal therapy you're talking about in that situation. So it doesn't compare different agents, but it does certainly give you an idea what your risk would be if you just took the hormone blocking agent. They are generally talking about, 5 years of hormone blocking agents, but there's certainly interest in trying to establish who might benefit from extended hormonal therapy. It's part of the test.
Thank you. Another one that's come in is, are all the side effects of tamoxifen fully reversible when you stop the medication? And I might add to that and say, and aromatase inhibitors too, are the side effects fully reversible when you stop the medication?
Mm-hmm. So let's do tamoxifen first. The short answer is yes, unless obviously you had one of those extremely rare unpleasant side effects of either thrombosis, obviously, which would require treatment, or cancer of the uterus, which would require surgery. But all the other hot flushes, changes in vaginal secretions, and all the other features are certainly completely reversible. The challenge, and the same with aromatase inhibitors, obviously osteoporosis or thinning of your bones is not completely reversible. So if you lose bone health on the medication, it's pretty challenging to regain that bone health. However, the stiff joints, the vaginal dryness should all improve when you stop the medication. The challenge for many people is that they have obviously aged 5 or 10 years while they've been on the medication, and they are comparing themselves with themselves 10 years ago. And of course, during aging, we all notice changes. So I think there are some patients who are a bit disappointed when they stop their hormone blocking agents and they don't feel like a new woman. And, I think sometimes some of the things they might have attributed to their hormone blocking agents were actually part of the aging process itself. But you don't really know that until you stop it.
No, true, very true. Another one that's come in. I am recently diagnosed. If I no longer have a period, but I'm still experiencing hot flushes and other menopausal symptoms, so am I still in menopause in terms of the hormone blocking medication? Will I be considered postmenopausal?
So for young women who are put on hormone blocking agents like tamoxifen, their periods might stop and they might get menopausal symptoms like hot flushes. However, they may still be premenopausal. So the tamoxifen might be temporarily making them postmenopausal in terms of their symptoms. But there are certainly some women who are not getting periods, who are on tamoxifen and who are not, and have been on it for some period of time with hot flushes, who will still ovulate. And so it's really something they have to be careful about. And unless you're really getting close to 50 or early 50s, for many of those women, when they stop tamoxifen, their periods come back. So the tamoxifen on its own will not put you through menopause. So the definition of menopause can get a bit murky around on women on tamoxifen, particularly if they're in their 30s or their 40s. So I typically wouldn't call them postmenopausal in that setting.
How often should you have a DEXA scan, which is a bone density scan?
So I would generally do a baseline scan before starting an aromatase inhibitor, and really the frequency of doing them moving forward from there is kind of dependent on what the bone health is like. If a patient has really good bone health, then I tend to do it every 2 years on the aromatase inhibitor. However, if they've got quite a lot of thinning, not osteoporosis or true osteoporosis, I would do it every year. The test is not subsidised more frequently than every 12 months. So if a woman goes in more frequently than, at 8 months, they'll actually be turned away by the radiology company. But really, it's important to monitor bone health, particularly the first few years on the aromatase inhibitors.
Now, this is a slight change of tack here from some of the questions that came in prior to the event, Michelle. Can hormone treatment safely be paused for pregnancy? And what is the effect if you become pregnant while on tamoxifen? And is pregnancy termination necessary, or can it be kept safely? By it, I presume it means the fetus.
Okay.
So we've got 3-in-1 questions there.
Okay. So there would be many young women diagnosed with breast cancer who were planning to have a family around the time of their cancer diagnosis. And for many, that is one of their greatest, their real grief about their cancer diagnosis is the impact it might have on whether they can have a child or not. We have good evidence these days that it does appear to be safe to have a baby after breast cancer. Certainly, we don't have great what we call prospective clinical trials. Obviously, they're never going to do a study where they take the women and half the women they allow to get pregnant and half they don't, and they see what happens. So they've really had to look back at what they call retrospective data. So looking back at women who've had babies after breast cancer. And obviously there can sometimes be challenges looking at data in that sort of situation, because probably the women who feel they have lower risk breast cancer are more likely to stop their medication for a period of time to have a baby. But if we use that data, it does not appear that having a baby increases your risk of having a recurrence of your breast cancer. In fact, some of the data would say it might actually even reduce your risk of the breast cancer coming back. So I would have many women, and one of the biggest joys of my job is when I get to meet the babies of girls that I've looked after, really at their lowest times when they were young and diagnosed with breast cancer and worried they'd never be a mum, and meeting them down the track with 1 or sometimes 2 children, it's an absolute joy. So that certainly is considered a safe thing, we think, a safe thing to do, but the timing of it can be challenging, and it's important to talk to your oncologist about whether they feel that that is safe for you and the timing they feel might be okay. Tamoxifen can be what's called teratogenic, so it can affect a fetus's growth and have an effect on usually the kidney system is what they've seen in the past. It's not necessarily a reason to have a termination. I certainly had one patient who accidentally got pregnant on tamoxifen and delivered a beautiful baby girl. So it's not necessarily a reason to have a termination, but obviously we would generally recommend women be taking precautions while on tamoxifen to not get pregnant. And if they did find out they were pregnant, to immediately stop the medication and communicate with their oncologist.
And I think, Michelle, that patient that had a beautiful baby girl, got pregnant with a beautiful baby girl while she was on tamoxifen, I think that beautiful baby girl is now a beautiful 10-year-old girl.
Okay. All right. Well, I'm showing my age. I'm showing my age. But, yes.
This is, I've got a question that's come in earlier, which is an interesting one. Someone is asking about hormone blocking therapy in respect of triple positive breast cancer.
Mm-hmm.
How important is hormone blocking therapy after triple positive breast cancer?
Yeah, look, it remains a very important component of that patient's treatment. So I know that it's a long haul, they've already had to do Herceptin as part of their HER2 positive treatment, but they also unfortunately do need to remain on their hormone blocking treatment because it's an important pathway in triple positive disease.
I wonder if we could just quickly address hormone blocking treatment in relation to triple negative breast cancer. Mm-hmm. Because there may be people listening tonight who have had that experience.
Yeah, so by definition, a triple negative breast cancer means that the breast cancer cells lack estrogen receptors, lack progesterone receptors, and lack the HER2 receptors. So breast cancer cells can have any combination of those three potential receptors or gates, as I like to call them, which provides targets for treatment. So triple negative patients don't have any of those targets, and really the mainstay in 2022 of their treatment is really chemotherapy. So there would be no role for a hormone blocking agent as an effective treatment in reducing the risk of a woman or man who's had triple negative breast cancer in terms of the cancer returning, unfortunately. We would love to have, a long-term agent we could use for those patients to minimise their risk, but we don't have it yet.
No, sadly not yet, but hopefully.
There's a lot of research in the triple negative space. So,
yes, there is.
Yeah.
What impact does a full hysterectomy, i.e. removal of uterus and both ovaries, have on the need for hormone blocking treatment?
Yeah, I think this is a really common question, and a lot of patients will say to me, Michelle, if I just had a hysterectomy, can I stop these tablets? And unfortunately, the short answer is no. So we know that for a premenopausal woman, that if you take out her ovaries, you are lowering her estrogen level, but we would generally not consider that to be adequate treatment to minimise her risk of breast cancer returning. She would still need to take either tamoxifen or an aromatase inhibitor to further reduce her risk. And for a postmenopausal woman, it will have no impact on her risk of cancer recurrence or the need for tablets, because her ovaries are not actually pumping out any estrogen anymore. As I mentioned at the start, it's going to be the fat cells that are producing the estrogen, and you can't unfortunately remove all your fat cells. We've all got them. So the surgery might make a younger woman's treatment easier, and that she may not have to have that monthly goserelin injection anymore if that's what she's been prescribed. But for a postmenopausal woman, it won't have any impact. And a premenopausal woman would still have to take her tablets.
Another one, do you need it for DCIS, ductal carcinoma in situ? I was told not necessarily, so just had surgery and radiotherapy.
Yes, so DCIS by definition can't spread to other parts of the body. So typically hormone blocking medication is not given to those patients to minimise the risk of that DCIS returning. However, there would be some women who have DCIS who we would talk to them about what we call secondary prevention, so trying to reduce the risk of them developing other DCIS or invasive cancer. And often it's those women who are quite young or who have a large area of DCIS, particularly if it was high grade, or if they had a strong family history. So it wouldn't be routine for women with DCIS, but for some women with DCIS, it might be discussed as a preventative drug.
Another one that's coming tonight. Can you test hormone levels to check if AI is fully suppressing ovarian function? If so, how? i.e. AI for metastatic breast cancer.
So you can measure hormone levels, and particularly looking at what's called the estradiol level, which is the main active form of the estrogen in your bloodstream. And for a woman, if you are worried that they might still have some ovarian function, you could do that and watch things very carefully. So in a woman with metastatic disease, often these women have been on goserelin for quite a long period of time if they were diagnosed earlier. And at some point we would, talk to them either about having their ovaries removed or, cautiously stopping the goserelin when they're perhaps in their 50s and really watching those hormone levels. And often women do know if they're having reactivation of ovarian function. They often will say that they notice that vaginal dryness settles and they're starting to have increased vaginal secretions. And they will often say, actually, now that I think about it, I can't remember when I last had a hot flush. So sometimes the woman knows before the treating team that their ovaries are waking up. And clearly we don't want that to happen if you're on an aromatase inhibitor, because that means the medication is not effective because your ovaries are making estrogen that medication can't suppress.
Mm. Can you take a break from hormone therapy? I saw something online which suggested you could take a 1-month break each year.
So there are a few different scenarios. The first thing to say is that we've got very good evidence that if you've taken your tablets for 5 years and you're needing to stay on it longer than that, that there's pretty good evidence that having a few months off each year, even up to 3 months each year, and being on it for 9 months is certainly just as effective as being on it continuously. So that we have very good data about. For women who are on their medication during the 5 years, it would be pretty common for most women at some point to maybe have a few weeks or a month off their treatment. We know these treatments have sort of long-term effectiveness, and so I generally am not concerned about patients. You know, some patients will say, Michelle, I'm going on a holiday and I really don't want to think about breast cancer, and that tablet's going to be a daily reminder. And obviously, you know, if someone's very high risk, we may not be as comfortable with them doing that. But for patients with lower risk disease, that may well be a reasonable thing to do. And again, I would encourage you to talk to your treating doctor. There would certainly be patients early on in their hormone blocking treatment who might be having really bad, there'd be a small group of patients who have really bad side effects. And I would often get them to have at least a few weeks, if not a month off, to sort of clear the drug out of their system before I try another drug. Because if I just keep hitting them with one medication after another and they have a really miserable time, for some of them I know that they're really going to say, Michelle, this is all too hard and I'm not prepared to do it, which I completely understand. So it's really about, you know, making sure that you are taking things gently in that sort of scenario. But again, it's all about, you know, I have my own opinion. It's important that patients discuss this with their own treating oncologist.
Yeah. Does everyone stop their periods when they're on tamoxifen? I still get my period. Does that mean tamoxifen is not working?
No, not at all. So, you know, it depends on your age and how powerful your ovaries are, basically. So there would be some women who would have a period every single month while on their tamoxifen, and it'd still be an effective treatment in reducing their risk of breast cancer returning. You know, some women who will ring my rooms, you know, they haven't had a period for 6 months and they get a period, and, you know, that they feel really anxious and frazzled and are ringing to let me know they've got their period. You know, it's not make or break if you have a period for most women with breast cancer. For some women with high-risk disease, there may be concerns that maybe we need to suppress their ovaries. But, you know, usually an oncologist will have discussed that with the patient early on in the piece. So I certainly don't think patients should be troubled by the fact they're still having their periods. The only concern, as I said before, is making sure you don't get pregnant.
Yeah. Is there any risk of eating foods which contain a high level of phytoestrogens, such as soy and flax, when you have an estrogen-responsive cancer?
So this is one of those tricky questions that, as a general rule, I just say a healthy, balanced diet is the way to go, everything in moderation. There's been 2 big trials looking at soy-based products and risk in terms of breast cancer, and one suggested that they might be harmful and one suggested they might be protective. So who really knows based on that sort of information? I think, you know, you'd really have to be eating massive amounts of soy-based products to having a lot of exposure to phytoestrogens. So I just really caution everyone to try and keep everything as sort of, you know, like the food pyramid says to do, not really, you know, going crazy on any particular food group.
Thank you. If you are going on a long-haul flight, should you do anything special before flying, or just continue to take as normal tamoxifen? What are the impacts around travel and blood clots?
So, I mean, it's exciting we can actually talk about that again, really, isn't it? So we know that long-haul flights are a risk factor for DVT, and I've already mentioned that tamoxifen is a risk factor for DVT. there are some general principles about how to manage yourself while on a long-haul flight, while on tamoxifen, and they include some women and men would use the compression stockings. However, they obviously make you pretty warm, and a plane's already a pretty warm environment, so some patients don't find that possible to do. But if you could do that, I think that's a good strategy. I would generally say to patients, it's really important you do regular exercises, you know, the little DVT exercises that they show us at that little video that people tend not to watch when we get on the plane. And also make sure you keep well hydrated. So don't drink too much alcohol if you're in the nice bit of the plane, and make sure you're keeping your water consumption up. In terms of other approaches, some oncologists will talk to their patients about stopping their tamoxifen for a short period of time before the flight. You know, it's not really, there's not strong evidence about doing that. And then a lot of patients kind of get quite mixed up with their time zones and where they are with their treatment. So it's always important to talk to your treating team before you go on a long-haul flight. There are not international guidelines about how to do this, and some oncologists are a bit more cautious than others. And some patients would even think about having a dose of a blood thinning drug the day before they got on a plane with tamoxifen, but that's certainly not standard of care and not something I'd typically recommend.
Another one, it says, I have been getting blood clots. Could that be linked to the letrozole that I'm taking?
So typically we don't believe letrozole increases your risk of clots. Obviously, it would be important to be seeing a haematologist and having screening to make sure there's no genetic predisposition to getting blood clots, but typically we don't think letrozole increases your risk. It's really just tamoxifen.
Another one, thanks Michelle, says, can doses of endocrine therapy be halved with the same effectiveness, e.g. 10 milligrams of tamoxifen instead of 20 milligrams?
That's a good question, and it's a bit so the short answer is the recommended dose for a woman who's had invasive breast cancer is 20 milligrams of tamoxifen. And that really, generally speaking, we don't have any evidence in 2022 about lower doses being as effective. There was a trial a couple of years ago looking at women with DCIS. Remember, I said a small group of women with DCIS will use a hormone-blocking agent as a preventative drug to try and reduce the risk of further DCIS or invasive cancer. This was an Italian study, and in this study, women were given 5 milligrams of tamoxifen. Now, unfortunately, they didn't have a control arm where the other women were given 20 milligrams, which is really what we'd like to know. You know, was there a difference in that setting? But if you look at the results of that study, and we're always cautious when we compare trials because, you know, maybe the groups of patients are quite different, but it's certainly been commented that the outcome of those women might be similar to previous studies in DCIS using 20 milligrams of tamoxifen. Now, that this needs further validation with a clinical trial, but, you know, some women will say, I can tolerate 10 milligrams of tamoxifen, but not 20. And as long as they really understand that there's not strong evidence about that, then, you know, it's again something for the patient and their oncologist to work on together.
We've had quite a lot of questions coming in about the effects of hormone blockers on bones and teeth. So I might just go through a couple of the questions and then whether you might want to bundle up into one response. So one person has said, if a woman has thinning bones and is on aromatase meds, will Zometa maintain the bone or are other medications needed? And another one was, why do oncologists immediately jump to injectables when managing early osteoporotic changes with the inherent, oh gosh, I hope I get this right.
Osteonecrosis of the jaw.
Thank you. The prophylactic tooth extractions that may be needed over the next 2 to 3 years, rather than begin oral alternatives as per Osteoporosis Australia guidelines or guidance.
Okay, so it's a good question. Obviously, oncologists put patients on aromatase inhibitors, and we certainly do not want to leave any of our patients with long-term implications in terms of their general health from our treatment. And if you start with a woman having poor bone health or osteoporosis or borderline osteoporosis, we get very anxious about what might be happening to her bones in 5, 10 or 20 years' time. And we do know there's good evidence that these drugs, such as zoledronic acid or Zometa, or Prolia, otherwise known as denosumab, or oral, there's also oral drugs that are used for osteoporosis. And we probably do have a pretty low threshold to turn to these drugs to try and maintain a woman's bone health. There are challenges with these drugs about this extremely rare side effect called osteonecrosis of the jaw. And I can't tell you how quickly it makes a patient's face scrunch up in a very unhappy way when I start talking about this rare side effect, because it does sound terrible. You know, this is where a patient has a major dental procedure like an extraction done while on one of these bone agents. They have a risk of being left with a permanent hole in their jaw. Now, this side effect is extremely rare. It's mainly seen in women, unfortunately, with stage 4 disease who are taking these drugs far more frequently. So often these patients are on these medications monthly, and often on this medication monthly for years. And in certainly that group of patients, osteonecrosis is something we're very cautious about. But for women with early stage disease, it's really, really rare. And, you know, it is that balance between making sure we've got you on good breast cancer treatment but not leaving you with long-term complications. I think moving forward, if there is good evidence that an exercise physiology program or physio program can actually be shown to improve bone health, that's going to be a really exciting improvement and obviously minimise the number of women with early stage disease that are going to need to go on these bone modifying drugs.
Gosh, thank you. One that came in earlier says, I am a women's health physio and would like to know about options if vaginal estrogen isn't possible, when it can and can't be prescribed, especially if the patient has prolapse and requires a pessary for supporting the POP more so than sexual intimacy.
Okay. And see, that's good. That's a topic I didn't really cover about involvement of physios in pelvic floor management for our patients. Look, I do think, generally speaking, oncologists are becoming more comfortable with the use of topical estrogens. I think they really are, you know, a very localized treatment. And I do, you know, it is certainly something that when I was at the menopause clinic at the women's, you know, it was always discussed with women, but they were always told to return to their oncologist and get clearance. But if you're not able to use those sort of agents, you know, that really can have a negative impact on, you know, the, you know, prolapse and other complications of, you know, pelvic floor dysfunction, all those sort of aspects from a physio's perspective. And presumably that leaves a woman in a situation where, you know, more invasive surgery may be her only other option, unfortunately.
If a woman is already post-menopausal at the time of starting hormone-blocking treatment, can she still expect extra weight gain?
Yeah, some women do still see it, but it's certainly by far and away more common for women who are going through menopause, either because of their chemo or naturally. So that's really the group where I see the greatest weight gain, and really caution women to be super careful for the first 3 to 6 months in terms of really ramping up their exercise and really trying to modify their diet. I mean, as a general principle, I say, you know, carbohydrates are the enemy of the menopausal woman, which is extremely disappointing because carbohydrates are very nice. But, you know, there really is definitely a slowing of metabolism around that time. But there are certainly women who are, you know, in their 60s and 70s and have been postmenopausal for a while, who do say they feel they've put on weight when they've started their hormone therapy. And it's again back to, I think, just more of a slowing of their metabolism, really.
We've had a few questions on brain fog as well, and how it can be counteracted. And does it stay at the same level usually at the beginning of the treatment or all the way through treatment?
Yeah. And look, I didn't have a slide on brain fog, but I'm sorry, I could have talked for a lot longer, but time limited what I was able to get through. It can be a really major problem for some women. And, you know, I've had patients certainly who've stopped their endocrine therapy, their hormone blocking treatment because of their brain fog. I do think it does improve with time for most women. And it's, you know, I think there's a lot of interest in looking at apps and other tools that might sort of be like brain training treatment for certainly on those early months of being on your hormone blocking treatment to try and keep the different neuronal pathways within the brain working. But as a general principle, women's brains love estrogen, and it is challenging when we lower your level of estrogen, the impact it can have on your brain function. Particularly those women who've had chemotherapy recently and they've got, you know, chemotherapy brain fog, and then we put them on a hormone blocker and they've got that contributing as well. It can be a very challenging issue to manage. And I think, you know, the more strategies people use, you know, to try and, you know, write their lists and do all those simple things and hopefully with time see an improvement. But we do acknowledge it's a recognised phenomenon.
Someone's written, how do I get more energy? Help, please. I'm always so tired.
Look, I think fatigue is also similar to brain fog. It's a huge challenge for many women. I mean, I think step one is making sure they're sleeping well and they're not getting, you know, hot flushes or insomnia overnight, because that's certainly, you know, chronic fatigue is a consequence of that. I think the challenge that many women do have, and we're all guilty of it, is that we're busy, we're working, we're trying to do lots of other bits and pieces, and we don't exercise regularly. And I think one of the huge take-home messages for breast cancer survivors is that their exercise should be viewed just as important in their treatment as their hormone blocking drugs, basically. There is very good evidence that regular cardiovascular and core exercise reduces your risk of cancer coming back, is a very good treatment for many of the menopausal side effects, including fatigue. And in the trials, that's really been shown to be one of the most effective strategies. Hard to find the time. I think it's recommended 150 minutes over the course of your week of exercise, and that's really hard to find. But I generally say to my patients, you have to look at it. You know, I'm giving you a prescription for your exercise like I'm giving you a prescription for your letrozole. And you're going to have to try and find that time in the day to do the exercise. And I do hope for many patients that does improve their fatigue. Obviously, it's important also to make sure there's no other cause of fatigue like thyroid dysfunction or other health issues. But we do acknowledge it's a component of breast cancer treatment.
Oh, gosh, we're coming to closing time shortly, but I've just got a couple more that I'll go through, Michelle, with you. Mm-hmm. Is there anything new on the horizon for hot flushes?
There's a lot of research continuing to happen. I mean, oxybutyrin is the new sort of sexy drug, if there's such a thing, for hot flushes. So that certainly is the newest agent that does seem to be effective. But and I think really moving forward, if there were better centres running, you know, the cognitive behavioural therapy and the psychological approaches, really that's about sort of feedback loops and trying to reduce the response the body has to the hot flush. That really I think is going to be something really exciting moving forward. But I'm not aware of any other new developments that I've seen of late.
Might make this the lucky last. Are there any foods that can make a difference to side effects of letrozole and Zoladex?
No, I'm afraid is the short answer. Not that we know about in 2022. So I think, healthy, balanced diet and really focusing on those lifestyle aspects, and if need be, turning to medication if you need it.
Oh, goodness. Well, thank you. Look, I know we haven't got through every question, and as I said before, if we haven't answered your question because we've run out of time, thank you so much for submitting your questions, but please, we would encourage you to talk to your treating team with any questions, or contact the BCNA helpline. Just a bit of news. Please have a look on the BCNA website for upcoming events such as forums, podcasts, webcasts, and future Ask the Expert events like tonight. And if you're not already familiar with my journey, that's something I think many of you will be, but if you're not, my journey provides a lot of information for you, high quality evidence-based information and insights from many, many people diagnosed with breast cancer. So I would encourage you to go onto the website, read about my journey, and to look at the app as well for my journey. Sometimes these types of events can be quite emotional, and it's important that we all take care of ourselves. If this has raised any issues for you, please feel free to call the BCNA helpline. That is only open during business hours. Talk to family, friends, or if you are experiencing a high level of distress, Beyond Blue or Lifeline. And lastly, I'd like to say a very big thank you to the lovely Michelle White for all her insights and guidance tonight, and particularly thank you to everybody who has joined us for this session. Also to Redback, who have looked after us as far as the IT goes and made it a lot more easy. So thank you. We do have an online survey link. If you would be able to take 1 minute to complete the evaluation survey, which is in the chat section, that would really help us develop our content for future sessions that we do like this, because really it's what our audience requires. We also need to say thank you to the Australian government, who we receive funding from to do this Ask the Expert event. So thank you to everyone. And I'll say good night from all.